We're actually streaming now live via my phone. Better than nothing, eh? That leads up to the next talk. It's working. I just need to tell everyone what the actual YouTube stream URL is. I'm just working on that. So one thing at a time. But anyway, I can multitask. I can be the chair and everything else. So anyway, let's get on to the next one. Thank you, Stephen, so much for bringing that case to us. Nadia, you wired up now?
I think so.
Oh,
yeah.
yes.
Yeah.
All live. Fantastic. So Nadia, a good friend of mine, a colleague, and we're going out on the piss basically in a few weeks in Reading. Hey, with other digital teams out there. Nadia's come to talk about her SharePoint, but she says it's more than just SharePoint, and also the headaches and the heartaches related to that. Her title is Better Than Nothing, a case study of limitation developing a resource sharing hub for primary and secondary care. Nadia, over to you.
Thank you very much, Mark. Hi, everyone. That was a fantastic introduction. My name is Nadia Kuftinoff. I'm from the Integrated Care Board, commonly known as BOB, so Buckinghamshire, Oxfordshire and Berkshire West. And today I am going to be talking about a project that I worked on that I tried really hard at, and it didn't really go to plan. And I've included a lot of very open, honest things in here, so it's a chance for you to kind of see the process that I went through and maybe spot where I could have done things differently. I mean, everything's obvious with hindsight, right? So I know what's wrong, but I did it anyway. So we'll start with the problem. So there was a contract for a website which hosted shared care protocols and guidance, and nothing particularly fancy. It was just like a document resource hub, really. The current suppliers quoted over 40K to move the content management system onto a new platform, and we were like, no, thank you, we're not going to be doing that. It's a shared resource between different teams, so it was from the clinical commissioning group days, so there was no kind of clear ownership. It was just sort of purchased at a time when things like that weren't very well defined, and across different teams in the ICB, so predominantly medicines optimization and planned care. They saw the contract re-procurement or doing something about it as a digital problem, because website and website live in laptop, therefore digital. And there was no resource allocation at all to do any of the work. Human resource, financial resource, pooling money together wasn't an option, getting money from a team wasn't an option, and it was only me that seemed to be working on it, and then other people asking me, had I solved the problem yet? So I went to, I whizzed through a lot of these slides, but if you want to like get me to pause to take pictures or what have you, just give me a shout. I went to our digital primary care board, and the initial proposal was like, why don't we at least do some user research so that we can then go back to the teams and say, this is what people want now, this is like the kinds of things that you should be thinking about, we've got like some suggestions for you, and now you make the decision. And I gave myself a nice long timeline to do that, with like lots of lovely focus groups and interviews and thematic analysis and lots of UX and the plan was to do all of that and then give it to the people who were the decision makers ultimately and let them run with it. Immediately that went wrong, because we went into Opal 4 status, and Opal, for those who don't know, Opal 1 is everything's okay and we can manage stuff, and Opal 4 is there is no capacity anywhere to do anything. So that made data collection quite difficult because nobody wanted to talk to me. But I did muddle through, and I was quite creative about the ways that I engaged with people. So I went to people individually and had interviews that way. I spoke to people in the teams that had historic information of this website and its resources. Went to different boards, went to different directorates. I run something called the Bob ICB Digital Forum, and we have lots of people from primary care who come to that, so that was a quick way to get user engagement really in a pinch. And spoke to our clinical leads, and the ICB like executive team got involved as well. So what we've got here is just an example of like what I did with the data, the qualitative data that I got. So that little board in the bottom corner, that was like a live tool that I was using, and people were telling me things. Then I had the interviews and things like that, whacked that in a thematic analysis, and then that informed a Moscow, so a must do, should do, can do, won't do, and that was then what I used to inform going out to get requests for information from suppliers. So put that together, went out to, oh, the formatting's gone a bit funny, sorry about that. Went out to a couple of different frameworks. There were problems there as well. You have to be on a framework for like 2 weeks to get responses from people. Didn't have responses the first 2 weeks, had to go on a different framework to get responses the second time. And kind of see what was out there that matched the requirements that people had told me. Now, essentially, a website would have done the trick. and a website costs about £2,000 maybe to get set up. But people were being ambitious and saying, like, could we have integration and interoperability and things like that? And I'm not there to say, like, oh, that's a terrible idea, because it's a great idea, right? So the scope for this particular thing was quite massive, and in return we got quite massive products come back to us, which weren't really fit for purpose. And these were like, £150,000, so there was absolutely no way that anybody was going to say yes to it. So already it was getting, like, the scope creep had crept. And we got lots of new requirements that were emerging from our stakeholder groups, including wider accessibility. So I had pitched the idea of, well, why don't we just make it a SharePoint? And people were kind of okay with that idea, but also said, oh no, but we'll need people from like trusts to be able to access this stuff. And I was like, okay, so we're back to the website idea. Anyway, we started going around in circles a bit. I went to talk to our communications team, who told me, like, we could have a microsite on the ICB website, but we are going through procurement ourselves, so it's not really a good time. So I was like, all right, okay, then we need to get some money for an actual website then to replace what we've already got. The website we were replacing, by the way, I should have said at the start, is called Clinox. And then nobody had any money. Nobody was willing to put a project team together to migrate the content from the old website to a new website. The deadlines were really tight. Eventually it got to a point where SharePoint was the only answer, because otherwise we weren't going to have anything at all and everything was just going to disappear. And I made a decision and went, right, I'll just do that then, shall I? So that's what I did. The picture on the left-hand side is the old Clinox website. The picture on the right-hand side is what I managed to make in SharePoint. It looks exactly the bloody same. This is like the simplest thing you can do in SharePoint, so it's not that much of an achievement. But I mocked up like a front page of the SharePoint just so I could show people what I meant, because I found that when I was telling people, oh, don't worry, I'll make a SharePoint, they were panicking. And I was like, no, you don't understand, it's good now. So I made it look as close to the original as possible. And this is like essentially Clinox was just like a list of stuff, so I was able to kind of recreate that in almost exactly the same way. And I know it's like the most boring thing in the world to look at, but I'm really proud of it. So the access question, I was like, all right, found out about this thing called guest accounts into the NHS tenant. Don't know if anybody's come across these before, but you can create an account for someone which expires after 90 days. You restore it, it lasts 180 days. It's just like a constant cycle of that kind of a thing. And if you're on an approved domain, you can get into the SharePoint, absolutely no problem. Except that there were lots of limitations to that, some of which I didn't realise were happening until they were happening, and then it was too late to go back. We'll talk more about that in a second. So this is what the new timeline looked like. It's kind of gone down a little bit, but I went from having like months to do something to 6 weeks to migrate an entire website over to a SharePoint and like build the SharePoint to accommodate that. So that was great. Here's sort of an example of a product backlog. So this over here, that's all of the stuff that I had to do just to migrate stuff over. And then we have like some outstanding actions and things like that. As well as doing all of the work for the SharePoint, guess what else? Like comms and engagement, right? So I had like a lot of different audiences. I had to create a lot of different things to send to a lot of different types of people. That took a long bloody time. All of this is made by hand. I got stuff in our GP bulletin, in our like patch bulletin, we call it the Bob Buzz. Bob is such a silly place. And then like webinars and stuff like that. I had loads of training sessions for content managers, for people who just wanted to see how the new SharePoint was going to work, etc. I was holding stakeholder engagement meetings, going to boards of different varieties, like having individual meetings with people who couldn't make the other meetings. It was a lot of effort. And guess what? We ran into more problems. So one of these problems, I'm not going to spend too long talking about this because I hate it. So there are these websites called formularies, and it's got like stuff on them. It's a very broad overview. There were over 1,000 URLs on the Oxfordshire formulary which pointed to the old website which needed to be updated. As you can see, I developed some code to scrape them all and then had to change them. Fortunately, at this point, I did get some resource, and the good-hearted people of the medicines optimization team. This is a user guide I wrote on how to go into their formulary, which I'd had 10 minutes of training on, and then update the spreadsheet. Like, it was so tedious. Like, this took so much. Oh, I hate it. I hate it. So turns out that this is no fun whatsoever. There's a lot of problems with the NHS guest account portal, which I didn't realise would happen until it was happening. Even things like, so when you create guest accounts, it appears as a table. You can't organise the table alphabetically. Like, you have to go through, like, you can sort of organise it alphabetically, but it's not truly alphabetically. Like, sometimes a D will randomly appear in the E section, and also I can't see the same thing that one of my direct reports who can access this can see. So it's just a bit rubbish. And it's very difficult to maintain, and also I shouldn't really be doing it. It's like a bit of a grey area of our SLA with our commissioning support unit, and they don't really want to do the thing that could make life easier, so I do the thing instead. And it's annoying because also I wasn't aware how big our stakeholder group was, so I thought, it's a couple of people in a few trusts. No, it's everyone in secondary care, so this keeps me busy a lot of the time. So doing all of that led me to burn out. And I did have to take some time off work because I was sick from doing all of this by myself. And when I say migrating the website and things like that, I was up until 2 o'clock in the morning sometimes. Like, I would finish work, I'd make dinner for me and my dad, I'm also a carer, and then I'd log back on and I'd work until 2 o'clock in the morning, and I did that for weeks and weeks at a time. So I burned out, and during that time I got COVID twice, a sinus infection, post-viral fatigue. I had 2 weeks and 2 days off work, and then I came back at it because the problems still were there. So that wasn't good. So I'd like to talk about where we are today. Have we reached the sandy beaches of collaboration? Are we gazing out over the tranquil sea of everything being okay? No, of course we're not. Shut up. I fooled you. The problems are still ongoing. New things are emerging which are a pain to deal with. We're moving a lot of the guidance onto the Bob ICB website, just kind of dumping it somewhere for now, because the guest access account has become so bad. Like, we can't stay on top of it. People aren't hearing about it. It's really, really awful. And the other team who use that bit of the SharePoint might also be doing something else. So all of that work might not need to be a thing anymore. I feel great about that. I'm not a big fan of Steve Jobs, but I do agree with this quote. If you want to take a picture of a slide, this is a good one. If you give them the tools, they'll do wonderful things with them. We were actually so close to this being a really good solution and not having to fork out and pay for another website or anything like that. The SharePoint itself is really good. Like, it's easy to use. The content managers have had their training. It's really intuitive. But it's the guest access that is an issue. And that's really annoying because you can get federated access and approved domains and all the rest of it, but it's still reliant on me and one other person in the team ensuring that that guest access can happen, because we're not allowed. Like, there's just so many things wrong with it. There's so many points of failure. And we were so close. We were so close for this to actually be like really good and useful. We have people from across the country requesting access to the SharePoint, and they love it. They absolutely love it. And on that note, if you'd like to see it, if you've got an NHS.net account and you scan that QR code, you can request permission to go into the SharePoint right now. My team monitors that throughout the day. If you require a guest account, I'd be happy to help facilitate that. Just let me know. That would be great. But yeah, to me, this is a lesson in, like, I tried my best with what we had to save us money, and it ended up costing a lot more than just money and time. And I'm disappointed that the things that we had to hand, I tried my best, I tried so hard, and it just didn't quite work out. But it is better than nothing. Thank you very much.
Thank you. Can you hear me? Yeah. Thank you so much, Nadia. Fantastic talk. Right, so moving on with the next talk. We have got my friend and colleague from Great Western Hospital. We've looked after a few patients now since I've been working there. Alex is a neurologist. He covers quite a lot of turf, actually, Oxford and Great Western. And he's come along talking about his Migr.AI solution. Interestingly, we met working for a company called Canvas Medical in the States, using large language models to try and turn human-readable protocols into code. So we've got a joint passion for collisions through code, and he's coming along to sort of give his opinion on things. So, Alex, please do come up.
Thanks for inviting me. This is my first time at this conference, but very excited to meet you all. So I've got half a foot in Bob and half a foot in BSW, and in my role in Bob, I'm the lead doctor for the community headache clinic. And in the headache clinic, we see a lot of migraine. It's about 99% of what comes through the headache clinic. Migraine is a very common condition. It affects about 20% of adults. As you probably know, the symptoms you get from migraine is severe headaches and a lot of debilitating symptoms that accompany the headache. So you get nausea, vomiting, light sensitivity, sound sensitivity, and it really impacts on work. So it may surprise you to hear, but the WHO recently published the global burden of disease, and migraine came third in the world as leading cause of disability after stroke and neonatal encephalopathy. And that might sound a bit outlandish to you, but it's just such a common disorder. There's not many things that affect 20% of adults. Luckily, we have a lot of good treatments for migraine now. So in the past 15 years, really, there's been a sea change in what we can offer patients. So the first development was a discovery that Botox can help patients with chronic migraine. But really, in the last 10 years, we've been using, well, more like 5 years, we've been using treatments that are targeted at migraine biology. So if you look at the bottom diagram there, that's the yellow cells there are the trigeminal neurons, which are responsible for signaling pain in the face, and they're overactivated in migraine, and they release a neurotransmitter called a neuropeptide called CGRP, and we know CGRP is involved in migraine because if I were to inject one of you with CGRP, you'd get a migraine, and so therefore the pharmaceutical industry's developed blockers for CGRP. So there's two types of blockers we have for CGRP. We've got monoclonal antibodies, which target either CGRP or the receptor, and we also have small molecules. And these are very effective, very well tolerated drugs. They're really a revolution, as I say, for migraine care. The problem is they're very expensive. So it's roughly $5,000 a patient per year. You know, multiply that by 20% of the population, you're talking a lot of money. So it needs to be properly monitored. Unfortunately, in migraine, we don't have biomarkers, really. You can't put someone in a scanner to see how bad their migraines are. You can't do a blood test. You have to monitor symptoms. And the main symptom you're monitoring, the main thing you're monitoring is headache frequency. So we require patients to tell us how many headaches they're having, and that's not just not me doing that. That's a nice requires that. So this is one of the nice recommendations for one of those antibodies I was telling you about. So this is Erenumab, and if you look at the red square, so to qualify for Erenumab, you have to have at least 4 migraines a month, and then to stay on Erenumab, you have to show you have a 50% reduction in migraine days if you have episodic migraine, and 30% if you have chronic migraine. So migraine days is really how you qualify for treatment and how you stay on treatment. And so every self-respecting headache service needs to have a system for dealing with migraine diaries, with headache diaries. And surely you're thinking there must be an app for that, and there are many apps, and maybe some of you use those apps. So we are partnering with a company that was started by a headache clinician, who's made a really nice app called KefRef, where you can, on the right side you can enter whether you're having a migraine, how severe it is, and have you taken an acute medication for that for that headache, because we want to know if people are taking painkillers and triptans and so forth for their migraines, because that can actually, if you're taking too many in a month, that can actually make headaches worse. So it's an important marker as well. And then on the right side, you can see, you can get a nice readout of headache frequency and so forth. So we're starting a pilot with that, but currently in the country and in our service, we're still using paper. And my feeling from speaking to other clinical services that have put digital diaries in is you don't get 100% penetration in your patient population. You get about 60%, 80% if you're doing well. So that's still 40%, 20% of patients who are not going to use the digital diaries and who are going to be giving you paper diaries. And we're lucky in headache that we've got the British Association for the Study of Headache. They make the kind of canonical headache diary that's used in most of the country, actually. And it's very simple. It's actually a bit of genius, in my opinion. I didn't design it. Okay, but the reason it fits on a page. It's very dense information, and it doesn't allow the patients a lot of space to ramble and write things that aren't relevant. So as you can tell, each square is a day, and you can write there whether you had a headache or a migraine and whether you took some medication. That's kind of the basic format. I filled this one in. And you can read out very quickly if people are doing well. So just by looking at the density of squares, essentially. So anyway, as a kind of side project, proof of concept kind of thing, I've been building software to read paper diaries, essentially using AI techniques. So this is my GitHub. Again, this is like Nadia. This is after my, I don't look after my dad. I look after my kids. But when they've gone to bed, I do a bit of coding, and so I'm working on two things: a system to read the Bash paper diaries using convolutional neural networks, and a free-form diary reader using large language models. And I'm using all open tools, so PyTorch, OpenCV. I guess Claude isn't open, but that's what I'm using as my LLM. So as I say, it's all kind of proof of concept. So for the Bash diary reader, what I do is I use the Bash template, which you just download off the Bash website, and I use OpenCV to register the picture of the filled-in diary to the template, and then I cut up every cell. I cut up the diary by cell, and then I've trained a convolutional neural network to read to sort of classify the cells into migraine, non-migraine, and so forth. I've tried, just OCR software. It doesn't work. I've tried even just putting the Bash diary into GPT Vision. It just makes up the data. So I've tried some off the shelf stuff. You really have to kind of make some custom things to read this, unfortunately. So this is my kind of first prototype. So this is just again with my handwriting. So there's a couple of mistakes in there, but it's doing pretty well, and I have an interface to kind of for the clinician to hand correct the paper diary. So to compare what we're currently doing now. I mean, to be, we don't even have a digital diary for the moment, so it's all paper. So right now we're just hand reading all these paper diaries when we get the patients. So already having something like this would be an improvement. And you can read out the stats just quickly. Whereas now we're having to count the cells ourselves. It's so embarrassing to tell you that, but that's the way our system runs currently. So again, proof of concept, but I think it's certainly possible to build a system like that. And really, I'd be happy for someone to steal my code and put it into their app reader, but or you may want to take the code and use it yourself if you're doing if you got a headache service. Now, so as I said, I think even if we had a digital diary service, there'd be a large proportion of people who wouldn't use it. And then even if you tell people to use the bash diary, some people just insist in giving you something like this, you know. So if, I don't know if there's any clinicians but sometimes they just, you know, people hand you a list of papers and they say, here it is. I would call this more a journal than a diary, but you know, patients sometimes that's what they want to give you. So I think there is a role, although I think it's a small role, for having a kind of a system that reads free-form diaries. You know, and so the ultimate aim would be to be able to read the handwriting and then process it by a large language model and just extract the data from there. Now, having tried some of these things, I think the OCR systems or even GPT Vision are quite there to read the handwriting. So I'm currently working from the second stage, so from digital freeform diaries into transforming into data. So you know, this is a kind of thing you might get, you know, where it's kind of descriptive. People write sort of half, you know, sort of inchoate descriptions of their symptoms, with some dates next to them, and you kind of have to translate it into, is it a migraine or not? Now we're lucky in headache medicine. There's some very good validated criteria by an international body called the International Classification of Headache. So there's some very kind of good validated criteria for migraine, and so what I've been doing essentially is I've using Claude Sonnet. I've got a prompt where I using the disease classification criteria. I read out diaries like I've shown you, and you can output something like that. So it's again proof of concept, and obviously, you know, there's all kinds of issues around using LLMs in clinical practice. So it's not, you know, this is very, very far from actually being implementable. It was just to show that, you know, I think there's some space in symptom tracking for using techniques from AI to interpret and extract data that's actually clinically useful for us in day-to-day practice. Thanks for listening.
Hi. Could all the speakers please come up to the front? We'll have a joint Q&A session. I need 2 people to help with roaming mics as well. Anyone available? You're one of those people, and I realized, yeah, you can run around. Fantastic. We haven't got any questions at the moment online, but we do have 32 people that have joined us now. Yay! Yeah, I'm surprised they managed to join us, but it's all sorted on the digital side. It's running via my phone. So that's plugged in, so the battery won't run out, so fingers crossed that's all good. Did I see a hand? Oh, fantastic. Marcus, jump straight in, please.
Is this on? Yes, it is. I thought all 3 were great, and I had actually questions for all 3 of you, but I'm going to just ask Nadia, why does this guidance portal need to be behind a login wall at all? Because it seems like that's your main headache.
Yes, I know I might answer that question. Thank you, James. It doesn't. So we do have like some role-based access permissions on certain files and certain pages within the SharePoint, but that only exists because we have so many external people coming into that environment that we then had to kind of figure out that sort of thing. It can be on a website. It should have always been on a website. It should have always been on a website, but at the time, nobody wanted to pay for a new website, and moving it over to the Bob ICB website, we were advised not to do that because of the reprocurement exercise that they were going through, and building a microsite was just, we would have ended up migrating things twice probably. So we were told, don't do that. By the way, we're still going through procurement. That was over a year ago, so there's not really much point in worrying. Just do the thing. Who cares? If I could go back in time, I would have just been like, shut up, we're just putting it on the website, leave me alone.
So there's a weird thing happening though there. We talk a lot about digital literacy of staff in the
Yeah.
NHS as though that's the project.
Mhm.
You've just proven absolutely that the staff can do this. What's in the way is the organisation. This is it's actually pathetic to see that, you know, a website cannot be built internally in an organisation when
Mhm.
you've got staff who can do the work.
Yeah.
It's crazy.
It
And
is
yet we do
crazy.
focus on digital literacy because that is not the problem, but it's the problem we would like there to be, because then we can go and train people and pretend we've fixed our organisations, and it's the organisations that are broken.
That is a really good point, Marcus. It was like the call was coming from inside the house. Like, it was definitely problems within the ICB, because I went to all kinds of boards. The exec team of the Integrated Care Board knew about this. I had a risk on our corporate risk register about the denied care for patients as a direct result of not being able to get this guidance, because this is like medicines guidance and stuff, you know. It's quite important to have that straight away. It was on the corporate risk register for over a year. Nothing happened. I did everything that I was supposed to do to get help, and I didn't get the help. And then we ended up with like a system that wasn't fit for purpose, that caused me more headaches, other people more headaches. The meds op teams all of secondary care have been emailing them being like, I can't get into the thing, help me. So they're annoyed, I'm annoyed. Yeah, if I could go back in time, I would have been stricter and firmer and just been like, no, this is going on a public place. But the answer's obvious when you know what it is, isn't it? Thank you, Marcus.
Can I just add to that? There was a similar thing here in Gloucestershire about its service, which was set up after 3 years of research, approved. Oh, sorry, it's not. There we go. It's on now. I thought I pressed the button. Yeah, a similar situation in Gloucestershire. There was this service which, wasn't getting any referrals. I was the first person who went along to it, and it was supposed to be a group cancer rehab service, and I was there with the instructor on my own for several months, and getting a lot of benefit out of it. And I asked, why is that? And I went fed back, and nobody could find out anything. You couldn't refer to it because nobody could find any information. So I said, I'll set up a website for you. So I produced a website in about 2 hours, because that's all it needed. And then lots of little cards so that people can then actually realised it doesn't need referral. You could do self-referral, and the patient could do it themselves. So you can actually have cards that the patient can do, and any patient who's been diagnosed with cancer can come along. That's not confined just to the NHS in this area. I'm working on a project to do with can community pharmacies be involved in improving early diagnosis of cancer? And we had a great project, very successful findings, and the outcomes of a research project in university are usually a paper and a report for an NIHR, but this was a stakeholder project. So how do we make that information accessible to the stakeholders, include the community pharmacists, GPs, but also patients and public? And so they asked me to say a microsite, and I was the only one in the team who knew how to put up a site. So I put up a site, and I did a podcast. And because the podcast was directed by me, everything was in public, understandable language rather than academic terms. So got an award for that. Putting things in the public place, when they don't need to be hidden, and a website is so easy to produce these days.
Fantastic, thank you. And I can see we have questions over there. Please fire away.
Yeah, I was just thinking with Nadia's problem, I've had similar problem with you create something that it's beautiful, it works, you've got all this stuff, but it gets hidden away behind the barriers. And of course, they need to be hidden away by barriers because there's things in there which confuse things outside. And you get blocked. I had one where we built something and the NHS email managed to block it because it decided it wasn't a valid website. And you end up with that same thing. And I've had the same thing with SharePoint and trying to get guest accounts. It's a nightmare.
It is sad to hear that this is a shared problem.
Yeah.
I've got a special little support WhatsApp group that you can join.
It's one in the past. But one of the things I'm thinking now is that I see so many problems that are clinical risk. They end up on the clinical risk registers. But they don't have the level of urgency about them. I talked to the ICB before about the risk registers. You find there's no clinicians who are assessing those risk registers. There doesn't seem to be a way of pushing that urgency of need. There's a lot of risk registers which pull out the financial risks or the governance risks, but the clinical risk, I think, falls flat. It doesn't carry through to the next level. I think there needs to be some kind of way of changing what's happening, I suppose, at the decision level making, because it's the clinical problems don't get high enough up the priority. So I was wondering if anyone had any thoughts on how to change those things.
I've been told recently, and this is very honest, by somebody in our governance team so I added another risk to the risk register because that's just my life and those are my projects. And they told me not to score it so highly because there are only a few risks on the risk register scored that high, and it means that it would have to go to the exec team. And I was like, yes. Yes. In fact, it's not even a risk anymore. It's an issue. It's happening. Like, it's happened. So so it's... Yeah. Oh, yeah. Yeah. Well, and you think like we needed $2,000, maybe $5,000 for a new website, like getting it set up and stuff. How much time did it actually end up costing? Like my time. I'm not cheap. And I spent a lot of time doing this. No, thank you. I'm a very expensive lady. So like if I had given somebody the numbers, like that product backlog that I had, if I had like put that under somebody's nose, because some people work better with quantitative stuff rather than qualitative stuff, right? So me going, this is going to kill me, versus some pie chart saying this is going to kill Nadia, perhaps. Yeah, lessons learned, isn't it? But I agree with you. Yeah, we need to be better at that.
Thank you. Have we got any more questions in the room? Or should we go and have some tea and mingle? Let's do that. So we're a little bit behind, but that's fine because we're getting things working. What was it? 11:01. Let's make it 11:15 back, if you could. Give you guys lots of time to drink and have a chat. Thank you so much, everyone. Can we have a round of applause for our speakers this morning?